This part of the respiratory series is going to focus on lower obstructive respiratory disorders, specifically bronchiolitis, asthma, and pneumonia. Just a quick refresher on where the bronchioles are and what the itis does, okay? So these are the smaller airways that are below the bronchi. So it goes bronchus, bronchi, bronchioles. And in bronchiolitis, those narrow airways swell and fill with mucus. So due to their smaller airways, young children are more susceptible to bronchiolitis complications. One of the primary causative agents is RSV, but other viral infections can cause the same physiological symptoms. So you may hear bronchiolitis or RSV in the hospital setting, but they effectively mean the same thing. It's important to note that a bronchiolitis infection in childhood is a significant risk factor for asthma. So bronchiolitis starts off like your basic cold, okay? We'll see runny noses, fever, some coughing, but where a child may improve after a few days, the bronchiolitis kid will get worse. The peak of symptoms is usually around days 5 to 7. So after 1 to 3 days of snottiness, this child will start to have more trouble breathing rather than getting better, and they'll have more increased secretions. And this will usually escalate until about the 5th to 7th day, and this is usually right around when they will end up getting admitted. As this progresses into the lower airway, we start to see more signs of respiratory distress, right? Tachypnea, maybe wheezes, but not always, crackles from the mucus. A lot of the patients who end up hospitalized are admitted for oxygen support, as they're going to be desatting on room air. Retractions are common, and if respiratory failure is imminent, we might see more severe signs of distress like nasal flaring, grunting, hypoxia, and cyanosis. These kids are very much at high risk of tiring out. So in the clinical setting, we want to monitor them closely, but especially paying attention to their level of consciousness and their respiratory rate and effort. This is a really common admission diagnosis, basically year-round these days, so you will likely become really familiar with it before the end of the semester. Additionally, we are monitoring skin and perfusion, O2 sats, and auscultating breath sounds to ensure that they are moving air. Bronchiolitis patients can decline rapidly, and it really is up to the nurse how often to check on these patients, and it does require clinical judgment to determine when to escalate care. Since bronchiolitis is viral, management is going to be supportive. If they are home, we're going to be encouraging hydration and rest, clearing of secretions, and comfort measures to decrease their energy use. In the hospital, it looks similar, but with the addition of supplemental oxygen, maybe some NG feeds if that child is too tachypnic to eat safely. That's usually if they're breast or bottle fed, and then continual monitoring for any respiratory changes. In order to keep these patients as stable as possible, we do have to clear their airway and try to make breathing as easy as we can. Babies are especially susceptible to complications because 1, they're obligate nose breathers, 2, they cannot blow their own nose, and 3, they rely on a pretty high energy technique for eating and drinking. So before feedings and PRN, you want to suction their nose. For oxygen support, we typically use high-flow nasal cannulas, which provide not only heat and humidity, but also precise control of the flow and the FiO2. And this is what a high-flow cannula device looks like, and you'll all get to see this at some point. It's basically a larger diameter oxygen delivery system that allows for more flow than you can get from the wall, as well as precise control of the fraction of inspired oxygen. So the heating and humidification is really important on these devices because dry air at those really high flow rates can increase the mucus due to the body actively trying to moisturize the airways. There is also a slight positive pressure here, which helps flush out dead space and improve CO2 levels. A very basic way that I like to explain this to students is to say that the flow, or the liter per minute, helps ease the work of breathing. So if the patient's tachypnic, retracting, irritable, increasing how much air passes through their nose in each breath will help. The FiO2, or fraction of inspired oxygen, helps to increase the oxygen saturations of the blood. So if they're desatting, despite being on a therapeutic flow rate, we can adjust the O2 concentration of each breath to ensure that they're oxygenating their blood more effectively. And just remember that room air, like off-the-wall oxygen, is 21% oxygen and 79% other stuff, mainly your nitrogen and your argon. So by increasing that percentage, we can increase how much oxygen is getting into circulation. Eventually, our patient will start to improve and we will want to wean their oxygen. And this can be a really slow process depending on the child, but our goal is to have them satting well on room air, eating and drinking fairly normally again, and demonstrating baseline activity or energy levels. Parents can be involved here. They can help oxygenation by holding their babies upright as much as possible, suctioning when they notice their nose is getting congested. It is well known that respiratory patients tend to be worse overnight, and this is due to a few factors. For one, probably the most obvious maybe, is that when you sleep, you aren't breathing as deeply or frequently, and and so this will naturally decrease the amount of air and could cause desats. Positioning can also be a factor. But another contributing factor is that our cortisol levels decrease overnight. And if you remember, cortisol is a steroid which decreases inflammation. And they've done studies on asthmatics, and that's demonstrated that that normal circadian rhythm that cortisol follows leads to less suppression of inflammation overnight. So we have a few compounding factors that come into play here, and it's why even if a kid's doing great during the day, we'll keep them for another night or two after they've weaned, because more often than not, a patient on room air at noon will likely need their O2 reapplied at midnight. As you can imagine, increased respiratory rate, fever, and decreased PO all contribute to fluid deficit. So we would shift to NG feeds if we see a respiratory rate over 60, since the amount of tachypnea can make eating an aspiration risk. If the child is tolerating feeds, IV access usually isn't required, but if they're really dehydrating and showing other signs and symptoms of fluid deficit, we absolutely will supplement with IV hydration. Bronchiolitis risk can be reduced similarly to other infection control measures. The one difference here is that there's a few pharmacological options to help prevent severe infection, and we don't see that often with viral agents, right? The one that's been around for a while is Synagis. Synagis is not a vaccine. It's important to note that. It is a monoclonal antibody that needs to be given monthly during RSV season, and that makes it really expensive. Up until this year, actually, this was the only option for prevention of RSV in high-risk infants. Now, in addition to Synagis, as of 2024, we have several other options for prevention of severe RSV, and this also extends to the older population. Nirsevimab is a newer monoclonal antibody, and that can actually be given once for the season rather than monthly, which, as you can imagine, is far less traumatic for everyone. We also have two vaccines, one for adults over 60, and then one for pregnancy between 32 and 36 weeks between September and January. So these options decrease the healthcare costs of prevention and also provide an option for the older adult now, which is great. As far as teaching goes, it's important to let families know that you can get RSV multiple times. It's easily spread in households, so hand hygiene and other infection control measures should be discussed. We should educate about how to safely suction at home and to know when to seek medical care, as well as encouraging fluids and treating fevers. Pertussis is a vaccine-preventable bacterial infection, that was a mouthful, which you may have heard called the whooping cough. So it is caused by the aptly named B. pertussis, which is a doozy of a bacteria that releases toxins that will attack the cilia in the respiratory tract. So this is particularly dangerous for infants who haven't had the vaccine yet, which you would get your first at 2 months. And it's why current evidence supports vaccinating between 27 and 36 weeks of pregnancy so that those maternal antibodies can be transferred to the baby. This can be really scary in newborns. Older kids can usually be managed at home, but it's still really uncomfortable. Symptoms can last for almost 3 months. This cough can be so intense that apnea can result, and small infants can get tired really quickly. Pertussis is often diagnosed symptomatically, but due to the severity and the duration of symptoms, antibiotic treatment should be initiated within 3 weeks. So in this case, a nasopharyngeal swab can verify the infection so that antibiotics can be prescribed. I don't know how Carl handles this now. In the past, it used to be a send-out lab, so they would often swab the kiddo, send out the lab, start the antibiotic, and then wait for the lab to come back. But maybe they can do it in-house now. I'm honestly not caught up on what their lab is capable of doing, because normally it's like a 2-hour turnaround. But I recall historically it took us a few days to usually get back the pertussis results. Azithromycin is the antibiotic that would be used for this. So pertussis does present in 3 stages, the first being fairly mild, and it's often unclear at this point what the causative agent is. So stage 2, the paroxysmal stage, is when children are usually hospitalized. And so I'm going to show you on this next slide a video of these coughing spells so that you can see how it manifests.
And it just kind of fluffy. Uh-oh. There we go. Okay. It's okay. Okay, take a breath there, honey. Come. Oh, nice. There. There we go. Where's both? It's okay. Lucy, please. Here. It's okay. Oh. Mm. It's okay. It's okay.
So as you can see, pretty terrifying. And this was fairly mild compared to some presentations. There's not a whole lot you can do during these coughing spells. We provided blow-by at the Children's Hospital. The year that I was there, we had a pretty large pertussis summer, and I have not seen it nearly as often in the Midwest. So again, best prevention here is immunization, not only of the child and the parents, but early visitors as well during the first few weeks can help sort of cocoon the child so that they do not get this, because it can end up in respiratory failure. Asthma, it is the most common chronic disease of children and is caused most often by a genetic predisposition to heightened immune response, or atopy. Okay, it can be characterized into 4 types based on severity, and each category has a personalized plan of care in managing symptoms. Asthma is an allergic response that results in inflammation of the airway that results in impaired gas exchange and difficulty breathing. Patients with asthma will often experience bronchospasm, which is when the muscles lining the airways in the lungs tighten, and so this narrowing causes airway resistance and can be heard as wheezing on auscultation. Risk factors for asthma can be genetic, socioeconomic, and environmental. Puerto Rican and African American individuals are disproportionately impacted, with males more commonly experiencing childhood asthma. Females will tend to remain symptomatic later into adolescence. Family history and environmental exposures can also have an impact, so you can imagine that mortality rates are higher in low SES communities where lack of access to healthcare and other resources exist. Even just accessing medication refills can be challenging for some families, and preventative measures and medications with asthma are really crucial for effective management. Asthma exacerbations will present with coughing, difficulty breathing, wheezing, and a sensation of tightness in the chest. Asthma attacks are really scary, and they often will lead to anxiety, which just makes breathing more difficult. The child may feel restless, assume a tripod position, or even sweat. So beyond a physical exam and history, pulmonary function tests are used for the initial diagnosis. And this is partially why in children under 4 to 5, we usually don't see asthma as a diagnosis. Rather, it'll be something called reactive airway disease. Until they can accurately perform PFTs, an official diagnosis is usually held off. X-rays will show hyperexpansion, and patients should have a baseline X-ray on file. Allergy testing can also be used to help identify triggers that can lead to exacerbation. And finally, peak expiratory flow rates, once a baseline is established, are a great way for families to monitor at home and anticipate if an exacerbation is developing or if they need to seek medical care. This is a peak flow meter, and they can look buried in their design, but they all work the same way. Okay, the patient's going to stand or sit upright, take a deep breath, put the mouthpiece in their mouth, and exhale as hard and fast as they can in a single breath. And so this will move the marker up the device to indicate peak flow rate. They should then repeat it 2 more times and write down the highest of the 3 numbers. Most patients are given a goal based on assessments to help guide care. So they'll often have an action plan that would look similar to this. We use a stoplight strategy using green, yellow, and red. This easily lays out the steps that the patient should take based on their personal medication therapies, their symptoms, and their peak flows. The peak flow ranges are provided so they can easily refer to this sheet and match up where they fall, and then it will guide them to take a quick relief medication or seek additional medical care if necessary. Asthma management can be really complicated. We could probably have a whole day of lecture on it. And these personalized action plans are really helpful. But the main thing that they want to do is try to avoid those allergens. Obviously, this is not always possible. So for medications, we will use a combination of short and long-acting bronchodilators, inhaled corticosteroids, and other medications as needed to help maintain the level of control that they need. Ideally, we're using long-acting bronchodilators as a daily prevention medication, and then that's most often combined with a steroid, so you'll hear brand names such as Advair or Symbicort. If these fail, patients can take a short-acting rescue inhaler that is usually just an albuterol medication prior to exercise or during sudden symptoms. These others are all complementary, and we don't really need to dive into the details, but be aware that they exist. For kids, it's always recommended to use a spacer, as seen here in this photo, to ensure that they're inhaling the full amount of medication. They will also come with mask attachments for infants and young toddlers. Okay, we're going to move on to cystic fibrosis, the last topic for this week. This is an autosomal recessive genetic disease that develops due to an anomaly in the protein responsible for making mucus in your organs, and also how chloride moves through the cells. So you'll have 2 carriers, and they'll have a 25% chance of a child with CF, a 50% chance of a child as a carrier, and a 25% chance of no gene at all. The graphs will usually demonstrate this combination because Someone with CF is usually sterile, so parents with CF are rarer than those who are carriers. Cystic fibrosis genetic predisposition can be tested for prenatally. It's also included in the newborn screening done at birth. A real quick clip of Claire Weiland, whose full documentary is linked in the supplemental videos for this week, but I think she explains what CF is better than I can.
My name is Claire Wineland. Well, I've never really lived a normal life. Okay. Frail. No. Can't take myself seriously enough. Probably you're wondering why am I in the hospital? I have CF, cystic fibrosis. I was born with cystic fibrosis, so I was diagnosed at birth. Cystic fibrosis is terminal, and it is very much going to kill me. And it's just a genetic disease that causes an overload of mucus to accumulate in your body, which is disgusting. So it slowly causes your organs to malfunction and fail. Sorry. When I was born, my life expectancy was 10 years old. And then it moved to 13, then it moved to 16, and then 19, and now it's in 20s somewhere. Who knows, maybe 25. I'm hoping we get past 21. Like, I just wanna go clubbing once. Like, that's it. I don't ask for much in life. Sorry, Mom, if you're watching this. What happens is when you get to be a teenager with CS, you start losing all will to function because all you have been doing with your time is taking care of yourself. It's hours and hours and hours every single day of treatments. So I do my best, do my nebulizers, count out my pills, take my pills, cut the pills that need cutting, check my blood sugar, load up my insulin, do another set of treatment, do another set of puffers, do another set of pills, then do my breathing, then do my working out, then take a nap because I'm exhausted at that point, then wake up, then do another set of treatments. When it's really time to start sipping. Then eat a tremendous amount because I have to eat around 5,000 calories in a day or else I turn into a skeleton. And pretty much that's the routine for the entire day. I'm back in the hospital and I'm making this video from the hospital. I have been thrown into here for another couple of days. I've had 35 surgeries. I've spent a quarter of my life in the hospital. It's a very high maintenance disease. And you start to feel like you are not a part of the world, like you have nothing to give, like you're just a machine that is taking care of itself.
So what it does is it creates like a syrupy thick mucus that causes mechanical obstruction in your bodily organs. And this especially manifests in the bronchioles and the pancreas. So we will generally see respiratory symptoms, right? Frequent infections in the lungs. And then in the pancreas, it actually ends up blocking the digestive enzymes that need to get to the small intestine. So this can lead to inflammation of the pancreas and potentially lead to some pancreatitis or even some insulin-dependent diabetes. And as you can imagine, this all results in a lot of health issues. The earliest signs of cystic fibrosis include meconium ileus, failure to thrive, and salty skin. A sweat chloride test is the most reliable diagnostic. So even if a child has a positive newborn screening, they will then come in and they will have this sweat chloride test done, which just involves like an electrode that makes the baby sweat in one area of the skin. They will collect it and they will test it for chloride levels. So management of cystic fibrosis involves preventing pulmonary infections and managing symptoms by removing secretions and encouraging airway clearance. As you can see, this little girl in the photo has a CPT vest on, and that provides percussive vibration to help move those secretions out. From the GI standpoint, patients need to take pancreatic enzymes before every snack and meal in order to assist with digestion. They should be on a high protein, high calorie diet to combat malnutrition. A lot of these kiddos are really small for age, and they should also be taking fat soluble vitamins such as A, D, E, and K. These kiddos are hospitalized quite frequently and usually for extended periods of time for 14 to 21 day antibiotics. Life expectancy for cystic fibrosis has increased quite a bit in the last few decades, but still only about 50% of kids with CF live past 18. And there's a median life expectancy of about 40. And I will say just in like the early 2000s, they were still saying 30. So it has expanded quite a bit. But honestly, survivability of this really depends on the severity of the illness. Some kids don't show any symptoms until they're older. Some, are getting admitted in toddlerhood for complications. So it really kind of manifests on a spectrum, and that really helps to predict sort of the course of the disease process. Okay, so this concludes the lecture on lower respiratory disorders. Have a great day.